Now coming to the most important tool in patient with congenital heart disease, that is echocardiogram, and it is an invaluable non-invasive tool of assessing the intracardiac anatomy, blood flow pattern, physiological data. A good echocardiographic assessment by a skilled interpreter, the invasive studies can be totally eliminated. Ability to interpret anatomy and physiology accurately requires a skilled echocardiographer. Although the complexity produced by extreme anatomic variation and changing loading condition render intraoperative echocardiogram really challenging even by experienced echocardiographer, the pediatric cardiac anesthesiologist should develop basic competency to make intraoperative decision during critical intraoperative situation. Although it is complex, the decision taken by the pediatric cardiac anesthesiologist can determine the outcome. So, you should be skilled enough to interpret this data. For example, the child has undergone a tetralogy of Fallot report and there is an echocardiogram which you do. Okay, echocardiogram done. The child might have tetralogy with severe PS or it might be a tetralogy with pulmonary atresia. Here, in tetralogy with pulmonary stenosis, you do transannular patch and VSD closure and you divert the blood from the RV into the pulmonary artery. In case of pulmonary atresia, you do a RVPA conduit. So, whenever you do an echocardiogram, you should have a visual anatomy. You should draw a diagram and you should have an assessment of how circulation will be and what are the steps which has done and how the circulation will change. That is very, very important. So, you should have, whenever an echocardiogram is there, you should have a sequential of various steps and where to look at each point. For example, in case of a tetralogy of Fallot where repair is done, you have to look at the morphology type, what was done, whether a patch was put or an RVPA conduit put. That was the first thing you look at the echo. Second is, you look at the RV size and systolic function and you will assess the RV outflow. The second point will be RV, okay. That is very, very important, whether the RV function is okay and the outflow from the RV to the pulmonary artery is maintained. Next comes the prosthetic pulmonary valve function, whether there is any regurgitation or stenosis across the pulmonary valve, whether you have put a conduit or patch, whether there is regurgitation or stenosis or the conduit is functioning properly. That will be the third step in the assessment. The fourth point is the integrity of the VSD patch, whether any residual leakage is between the right ventricle and the left ventricle is there or whether the patch has given way. Next is the aortic valve regurgitation. Either aortic valve is functioning normally or the root is dilated. You look for associated defect like any ASD is there, anomalous coronary, whether the coronary anatomy is okay, persistent left ventricular superior vena cava, whether LSVC is there, and also look at the aortic arch. So, in a case of tetralogy of Fallot with echocardiogram, you have to assess in a sequential way. Similarly, for any other congenital anomaly, whether repair is done or not, you have to sequentially assess the echocardiogram. That is very, very important in managing this case in the intraoperative period.